My name is Katerina Iliopoulou, and I am the chair of the Nurses and Allied Healthcare Professionals Committee. Today, we have the great opportunity to have three excellent speakers who are going to present the ICU staff well-being, a very important topic and a priority for European Society of Intensive Care Medicine. Our first speaker is Katerina Rusinova, who is head of the Department of Palliative Medicine in the General University Hospital in Czech Republic. Katerina, the floor is yours.
Thank you very much. Good afternoon, everybody. I was given a task to speak about stressors in the ICU and preventing the avoidable and mitigating the unavoidable. I think it is not possible to speak about the well-being only from clinician perspective. It will be naive to think that we can be okay while our patient or families are not okay. So that's why I will take these three perspectives to have a look and maybe to open the floor for more discussion further. So first of all, from the patient perspective, let's talk about pain. Until I was a part of this wonderful study done by Kathleen Puntillo, Europain study in 2014, I wasn't myself aware of how much painful procedures in the ICU we are doing and how this affects the well-being of our patients. Let's see the most painful procedures like chest tube removal. Okay, wound drain removal, that's okay too, but it's not so often. But I would just like to pay attention and like to invite you to pay attention on like the things that we are doing multiple times a day, like turning, positioning, wound care, tracheal suctioning. These are all procedures that causing a lot of pain to our patients. And I heard once Diana Meyer, a geriatrician and director of CAPSI Institute, say, you know what, pain is medical emergency. You don't leave patient's room if the patient is in pain. So just to think about the well-being of our patient. And there are a lot of possibilities how we can assess patient symptoms and improve their well-being. And I think patient symptom management is at the core of our profession in terms of duty to care. And the advisory board that published a white paper in 2014 highlights all kinds of possible assessment approaches, not only for communicative patients, and that we all agree that it is easier to do, but also assessment of symptoms for non-communicative patients. We can also assess behavioral assessment. We can assess proxy and to ask simply the family, what is the patient experiencing? That is very effective to do it. And for that to allow the family be at the bedside as much as they can. And we can also presume the presence of symptoms of the patients that we know they are communicating their symptoms. And on the picture, this is a patient of mine a couple of years ago. Maybe you can see the belly of this young lady lying on the bed, which is a little bit swollen. There's a melanoma, and I'm sharing with her permission, with permission of the family, this slide. But it was only after we've been able to treat her pain that we were also able to discuss more advanced and more deeper things like discussing ICU admission, what we would do if she deteriorates, etc. So for the symptoms management is at the first place. It should be at the first place, and only then you can have 5 smiling people at the room and have a good discussion about what really matters to them. And in this third slide, I would like to remind you and to recommend two things. The first, a Jerry Pell podcast with Professor Randy Curtis that recently passed away. And in that podcast, he speaks about what is important for the well-being of the patient. And this is just a screenshot of his talk that highlights what is important for him as a patient. And the most important from his providers is that they care about him as a person. So this is another point from patient perspective. And I also like to invite you to read this wonderful paper by Randy Curtis and Mitchell Levy, two big head of societies, Critical Care Medicine and American Thoracic Society. It was published in the Blue Journal last year, and it's called Providing Compassionate Care in the ICU, another perspective for well-being of our patient and well-being of the healthcare providers. There are 5 points that they highlighted in the short piece: to be compassionate to others, being willing to be vulnerable as a clinicians, being willing to be present and steady in the face of grief and emotional pain rather than avoiding these strong emotions, and also being able to live with uncertainty. And the 5th principle, willingness to be wrong. These are great thoughts and insights for us to be sure that we allow our patients to feel comfortable, the most comfortable they can feel. Let's turn our attention to the family now, to the family well-being. And we know that there have been guidelines for family-centered care published a couple of years ago, and I think they nicely address the need that family has to experience the best they can. And these guidelines are around 5 points about the family presence in the ICU. We should allow the families be as much present as we can, allow for care of the patient too. We should be able to provide family support not only during the stay in the ICU, but sometimes also bereavement support. A big stress is put to the communication with family members, use specific consultations. It means invite folks like palliative care physicians or chaplains or psychologists into your ICU to support the family. It's worth it, it's proven effective, and it helps to promote the family well-being. And there's also operational and environmental issues. So instead of having the family feeling like that at that picture, you can have a family that is engaged in communication with the healthcare team, with the patient, and allowing also for like the normal life in the ICU for the patient and for the family. There have been a couple of useful things published, what you can do for a family. Just to mention one among others, communication brochure. This is the original New England Journal of Medicine paper. And this is our adaptation. This is what we use here in my ICU in Prague. Simple information that allows the family to feel better and to understand. And now in the last part of my talk, I would like to just share a couple of thoughts with you about stressors that we face as clinicians. And this is the first slide. And I was just thinking about there's a difference between us as clinicians in different phase of our career. In the apprenticeship, so in the early years, we have fear of making errors. This is the important source of our stress. Fear of omission or of adverse events. And we want to provide basically everything in terms of diagnostics or therapeutical maneuvers and procedures, then as we move with our career and as we acquire more knowledge, so somewhere between 10 and 15 years, we have, I'd say, no fear. It's a little bit exaggerated, but we have our knowledge at the top, and we want to provide the maximum that we can and that the evidence-based shown to be effective. And then there is the third phase in our career when we work like more than 15 years in the ICU. I often share with my colleagues the fear of more on the other side of the spectrum, so the fear of harming the patient, and we care more about providing compassionate care and do not do all the procedures, and to think about also the patient and the family perspective. So this would be like a broader look at the stresses that we might face as clinicians according to different, time trajectory of our career. And then I would like to present you another perspective to introduce the debate that we can have during this webinar. And this is more about the culture we inhabit in 2023 in the ICUs. And this is in 5 bullet points. I think that the culture that we inhabit faces and experiences tremendous and astonishing ascendancy of technology and therapeutics that have an impact of longevity and life quality. And we are seeing new treatments almost every day that lengthen life and that have far fewer comorbidities or toxicities, and they have a clear impact on life longevity and quality. But at the same time, this proliferation of technology with what I would say a tangible, like normal human fear of death makes almost a perfect storm where we experience ever heightened expectations, like on both sides, on both ends of those delivering the treatments and also those receiving them. And that may lead to the therapeutic relentlessness. It's not my term, but I think it's a nice one. And so we are living in our ICUs in the culture of therapeutic relentlessness, and this may become a norm. And so we might find ourselves in a situation that the treatment may become a metric by which we account for good care. And in that context, patients may become an algorithm to be navigated rather like human beings and persons with their sets of goals and preferences. And I think that, sorry, I will stay a little bit more at this slide. I think that these 5 points are my notes from a webinar organized by Lancet Commission on value of death and dying. And I am quoting largely Dr. Guglani, medical oncologist, whose thoughts these are. And I'm very much agreeing with him. And I think this is an important source of stress for us as clinicians in 2023. And this is why my last slide would be a call for a greater balance and a good ethical climate. So in the era of proliferation of technologies and even more things that we have on the column side of this scheme. So more and more therapeutics and procedures that may be indicated and that are, of course, our duty from the point of view, duty to save lives and to prolong life. But I would like to invite you to further think about the left side of this scheme. And this is the patient voice, and it stems from our duty to care duty to truthfulness and alleviation of suffering. And I think there is maybe some source of stressors that we can work on and we could target. And this was my last slide. Thank you for your attention. Thanks.
So thanks, Katerina, for that fantastic presentation. And I think introducing the concept of staff wellbeing like that was great. So the patient perspective, but also the staff perspective, and several things I think which we can all resonate with: the time that we've spent working within critical care, but also this concept of therapeutic relentlessness, which I think we all recognise. My name is Susanna Price, I'm a cardiologist and intensivist from London, England. Just to let you know, thank you firstly for dialing in, but to maximise the opportunity for discussion, we're going to go through all three talks and take the questions together at the end. And we do want to hear from you because staff wellbeing really is an ESICM priority. Please use the chat and that will be passed on to the moderators, and then we will take them and present them to the speakers at the end of, or towards the end of this webinar. So it now gives me great pleasure to introduce Elie Azoulay. He doesn't really need any introduction, but from Paris in France. And Elie is going to talk to us about understanding ICU burnout and its determinants, a really hot topic at the moment. Elie, over to you.
Thank you very much, Susanna. So I'm very pleased to present on something that is a major priority for the European Society of Intensive Care Medicine, is the mental health of all healthcare providers. So how can we better understand staff burnout in the ICU? There are many symptoms and syndromes that have been reported over the last 2 decades, coming from ICU conflicts to a very large myriad of mental health symptoms, going through moral distress, anxiety, depression, post-traumatic stress disorder, and burnout. The question here is, we are not psychiatrists, we are not psychologists, but we are still committed to recognize whether our colleagues, and maybe sometimes ourselves, even if it's not so easy, we should understand whether the colleagues have any sign of exhaustion, depersonalization, and reduced personal accomplishment. And this triad defines burnout. Exhaustion is not only a fatigue, but also an emotional depletion. Depersonalization is your ability to recognize that your colleague has changed. He became negative, cynic, and a lot of detachment where the person was very much involved, committed before. And there is also a reduced perceived efficacy and a feeling of incompetence, making that people always are thinking to be on sick leave because otherwise they think they are going to harm from the patient. You can see on this slide that there is a balance between pressure and our ability to cope. If we are really able to cope, we are going to be at the optimal level. Creative, we are going to understand that we can be effective and we can really have a very, very good professional time. However, if we are with very low ability to cope, for either the same pressure or even a reduced pressure, we are going to feel fatigue, exhaustion, and burnout, which is on the other side of bore-out. Stress versus burnout. We know that we are with very similar symptoms, but I think that it's very easy to understand that stress is too much pressure, too much demand, but you can still cope, you're stressed. But burnout is that when you have not enough, you feel empty, you feel depleted, you think that you cannot be full anymore, you are hopeless, and you are burned. This is burnout. Is burnout something frequent in our medical specialties? And you can see on this slide that every medical specialty is beyond 30%. But us, the ICU specialists with the emergency physicians, we are at 50% and even more according to circumstances. It is very insidious. No one is going to knock at your door and complain of the symptoms of burnout. And you just need to recognize that your colleagues might be stressed. They will be there, but still stressed. But when someone is burned out, he's not there anymore. It's not something acute. It's a prolonged stress disorder. So you have alarms, and we need, as ICU leaders, we need to be able to understand those alarms. We need to recognize when someone is in a phase of resistance. And of course, we know now the symptoms of exhaustion. When Dr. Freudenberger described the disease very early in 1974, there were three kinds of symptoms, and it's our commitment to understand what is related to working condition, what is related to imbalance with people's expectations, and what is a deficit in coping. And we need to listen to people and to be able to rephrase and to put everything in a track. When people complain about working conditions, either that it is unchallenging, or it's too much, or not enough, or it's chaotic, so then you know that it's something related to work. Sometimes, for a given amount of work, people have inappropriate expectations, too many things. They have overly demanding expectations. They feel they're not rewarded for good job. And sometimes it's about coping, and people are not getting enough, and mostly they are not getting enough sleep and enough control over their work. The causes of burnout are related to work, to lifestyle, and to personality. Work, when we have little control, little reward, excessive demand, little challenge, and a chaotic environment. Lifestyle is when the clear imbalance, little social or private life, too much expectations from colleagues, too much responsibilities, too little sleep, and no really privileged relation at work. And personality is a kind of personality where people are perfectionist, pessimistic, they need to control, they cannot delegate. We call that type A personality, but this is a very old concept that we need to rephrase in terms of new ways to address personalities. There is this framework making that the symptoms of burnout stem from personal characteristics, ICU environment, and organizational factors. And we know that there are elements that are making that we are going to make a decision based on those symptoms. We can either stay and develop PTSD and other psychological symptoms, or decide to leave. And this is one of the main problems that we are facing in many countries in the world. We are having this rapid job turnover leading to the situations of shortage, making that it is believed that in a few years, in 15 years, we will need more than 10 million nurses overall, and certainly 1 to 2 million nurses in our ICUs. So the contributing factors are clearly sex, age. When you have little experience, you are more at risk of burnout. When you are trainee, in the same way. When you're a mid-career faculty, when there is a high workload, long hours of night shifts and weekends, and the periods where you work more than usually, when it's stressful, when it's unsatisfactory, when there are conflicts, or too much administrative burden. And we know that it's going to really lead to decreased quality of healthcare, medical errors, patient satisfaction is going to decrease, the cost of care is going to increase, effectiveness at work is really bad, and people feel less committed. There's a high turnover and all the consequences related to nurse and physicians shortage. Catherine Maslash has been very, very productive. And this is the MBI, the Maslash Burnout Inventory, that is a 22-item tool that has been translated in many different languages and has a very validated thresholds to define burnout. And it's something that is really related to the healthcare environment. The thing is that this instrument can really depict the three different domains: emotional exhaustion, depersonalization, and personal accomplishment. And we know that there are different cutoff making that we can define low level of burnout, moderate or high level of burnout. And usually when we ascertain that someone has symptoms of burnout, it's only based on emotional exhaustion and depersonalization. Personal accomplishment is not part of the definition of burnout based on the MBA. However, in a first study, we were able to show that more than 50% of the ICU specialists, doctors, were with a high level of burnout. And that was the case in about 1/3 of the ICU nurses. And conflicts were really one of the major determinants of burnout in the nursing staff. It can be conflict with relatives, patients, other nurses, or physicians. In the COVID-19 wave, that was the second wave, we were able to collect information from a large sample of healthcare providers in France. And it was very interesting to see that only 10% of the healthcare providers with burnout had only burnout. Most of them had also symptoms of anxiety, PTSD, and depression. But still, burnout has to be defined as mirroring depression. When there are depressive symptoms, it's very difficult to ascertain that what you are observing is a case of burnout. And I think that we need to be really aware of the dynamic process. It's not something acute, but it's also something that you can stop at different levels. When you look at the downward spiral, you can see that there are many different signs that should alarm you and alert you that someone is really getting down, and he will or she will be very close to collapse. And this is very important to catch that at the right time. And otherwise, you need to take the time and help people build their resilience to reconnect with friends and family, understand what were their expectations, stop blaming others, define and think on the future. And I must say that often it's associated with also a change in the work environment. And this is how our nurses and doctors are leaving the ICUs. When we look at the consequences of burnout, we see sleep disruption and insomnia, irritability, eating problem, money issues. People forget easily, they have libido disorders as well as depressive symptoms. But we also know that it has consequences on patients and their safety. This is a seminal study published 20 years ago in the United States showing that there was an increase in patient mortality when we were adding a burden, physical burden to the nurses. And this was also associated with burnout and job dissatisfaction. So there is a kind of link between patient safety, job satisfaction, and burnout. And all of this leads to the intention to leave the ICU. And this is about the relationship between nurse burnout and patient satisfaction. This is one of the oldest papers, but other studies have reported that a good team, when they are really able to work together and to have a good healthcare environment, so burnout is less important and patient satisfaction is higher. These are the data that we measured during the first wave of the COVID-19. And as you can see, burnout was very high, more than 50% at this time. But there were huge discrepancies across countries and across regions in the world, making that there are other factors that are either cultural or organizational that are making that at some places burnout is much higher than in other. And we need to understand what are the reasons for this variability and how we can address burnout in every different setting. This is the typical picture that people understand, that now after COVID-19, after the pandemic, we are with a big nurse shortage because of burnout. I must say that this is part of the reason why nurses are leaving the ICUs, but it's not the only reason, and this is another discussion. So Margot is going to report on how we can deal with burnout with the 3R approach: recognize, reverse, and help people build their resilience. I just want to end my presentation with this catch. One, as ICU leaders, we need to delegate the leadership and help people getting empowered. This is a catchword, and you need to think on that. It has been associated with much less burnout, but this is also a way that something where we can really learn how to behave and how to really delegate and empower the colleagues. The second thing is that we need to be able to develop emotional intelligence at work. And this is also something that we can learn. So education and training is really a key issue in decreasing the burnout prevalence in the ICUs. And last, there are other factors that we need to learn and think about and organize at a department level to be really able to work on that. So my recommendation is that you should create a group in your ICUs, and we should all work together with the nurses and other elite healthcare professionals, with the medical team, as to build together an environment and a culture of the ICU that is safer for the mental health of ourselves and our colleagues. So burnout is not a fatality. And you have seen the different factors leading to burnout. And we also need to understand that it is something that we can prevent. We can prevent by catching the symptoms, listening to the colleagues, and paying attention to something that is a chronic stress and can really lead to a lot of damages. Thank you very much for your attention.
Thank you, Ellie. Fantastic presentation. Clearly, burnout is a very, very hot topic. It's important for employees, employers, patients, and relatives. And before we go on to our next talk, it has been recognised by the WHO in the ICD-11 coding as an occupational phenomenon, which I think is important. So it may lead to medical conditions, but it's not a medical condition in and of itself. It costs us and it costs our patients and patients' relatives and our relatives a lot, but it also costs money, up to 8% apparently of national healthcare outlays. So we need solutions, and Margot is going to provide us with solutions. So I'm very pleased to introduce Margot van Mol from Rotterdam in the Netherlands, who's going to tell us about what we should be doing about burnout. And her presentation is entitled Building Resilience and Work Engagement for ICU Healthcare Providers. Margot, the floor's yours.
Well, thank you, Susanna, for this introduction. And indeed, let's talk about resilience and work engagement. And what can we do about burnout? What can we do about the work stressors that we encounter? Oh, yes. If we think about resilience, and you see this in this word cloud, then most of us have a positive association with it. For example, resilience is vitality, stability, it is mental health, it is motivation, inspiration, but sometimes it's also negatively associated when you think about how can I build up that resilience and why should we do that? So we have to look and describe it more as the ability to bounce back in difficult situations. And several authors have mentioned it like this. And then you can see it in the picture. For example, if you have a bouncing ball and it's going to the ground, then it bounces back and it is not touched. It's different from, of course, breaking an egg, which is totally disrupted. And I think there is more between it, because if you have to deal with difficult situations, then it can change you. You are not the same person after that difficult situation. So when we have a more scientific definition of resilience, then it is the ability of systems or components thereof to respond to changing circumstances or disruptions such that essential features are restored. So there are two components that I want to emphasize. And the first is the ability to respond. And I think that is very important. We can have our mechanisms, we can have our measures, our manners to respond to the difficult situations. We can learn about that. And another part is that it is essential that you are in the core, you are building up the same and you learn from it. So resilience is the ability to recover, to adapt, and also we look at personal growth. Well, and I'm very glad also that it is the same for patients, relatives, professionals, and there are several factors that are influencing our personal resilience. For example, the physical well-being, what already was told about. If the patient has a lot of pain or discomfort, then his or her personal resilience will also be affected. Social involvement, very important, that we have a team spirit, that we have colleagues to talk with, so that can build up your personal resilience. So that alignment to work is for the professional a very important factor to look more closely. And I think this is already told, well, to provide high quality care in the ICU, it is increasingly complex and emotional demanding, and it has an effect on our job satisfaction, or how you are going to call, or your healthy working. And that can result in psychological distress, as Eli already mentioned, burnout, moral distress, all the other concepts, and we might encounter the hospital understaffing. So work-related stress is very important to look more closely at it. And as a counterbalance to work-related stress, then you can look more you can look at work engagement, and that is the opposite of work stress, and it is characterized as vigor, and that is the energy you work with. It is the level of vitality. The second part is dedication, and that is the engagement or the involvement. How are you involved in your work or in the team, or what do you want to do, and how are you inspired by that? And the third part is absorption or flow. And that is that if you are doing something very nice, for example, if you have a hobby or so, then you might forget the time. So that is meant by absorption. And as you can see in the figure, there is balancing. There are negative stressors working down, and there are positive factors, for example, the resilience, but also the social support and the sense of significance. And I was very pleased what Katrine already mentioned, that it's important to have that sense of significance, your identity as healthcare professional. Why are you working, and why are you feeling engaged? And that is really important to counterbalance the work stress. And that is derived from a theoretical framework, the job demands research model. That is work derived from Ciavelli. And if you look at the picture in the below part, then there are the job demands, which are figured out by Eli. The job demands in emotional, cognitive, and physical perspectives, all the work stressors, and it is draining your energy. You're running on empty. Your energy battery, you can imagine, is red. If you go to the upper part, that is the motivational process, there are the job resources. That are the factors that can have a positive influence on your energy level. For example, the social support, the colleagues which can have the talk with you, the team spirit and the team efficacy. So that will provide you with the energy, and that can balancing out so that you, in the end, in the consequences, you have the healthy working, successful working, or work engagement, or all the concepts that are in the positive side while we are working as ICU healthcare professionals. There are two factors. Well, there's also the leadership, and that's a very broad concept that can have a positive, but also a negative influence on your energy level. And important, the personal resources. And this is a very general psychological model, but the personal resources for healthcare workers, I think it is the social support. And related to that is that you can build up your resilience. And this is a beautiful study done in Pennsylvania by colleagues of COMES, and they were already measuring burnout and professional fulfillment before the COVID. And it's not surprisingly that during the COVID pandemic, that burnout raised and that the professional fulfillment, it lowered. But what beautiful is in this study is that they have the 3 elements of that professional fulfillment, and it is not only your personal resilience, but it is also the culture of wellness. So the organization, and how are you doing as staff, as team, as ICU department? How do you take care of each other, and how can you have that culture to look at each other? And they found 2 very important factors. Social support and meaning in work are protective for work-related stress. So what can we do? And there are a lot of things that we can do, but the first layer, most important, is that you have colleagues to talk to and listen to them. If they are having signals of exhaustion or are getting negative, listen to them and just talk with a cup of coffee, or if you're doing something. That is the most important thing that we can do within our team. Social support is ook your friends and family. They are well supposed to listen, but it's very nice if you have your social support from them. Then you can look at a buddy system, or sometimes called it peer support, and that is also social support, but then it is more formalized. And the second layer, then we look at the coaching and easily accessible psychological help. And it's really important that we know that we can ask for those help, and then we can have to talk and about our work, about the work stressors or what is bothering you, and also to look together what is your identity and why did you come back, what is your work as doctor or as a nurse or healthcare professional, and why do you like it? Why do you feel that engagement? And so that you can have that back and have that sense of belonging. Well, I think that emotional well-being is balancing, and that is the personal strategies. What can you do by yourself? What factors can help you? What can you learn? But it's also about the organizational strategies, and I will look at those both. And it was already mentioned that it's also a bit of personality, and that's difficult to change, although you can learn about it. If we see the glass of water, some people say it's half full, and some people say it's half empty, and it is the same volume of water. So that is a bit of the core of yourself, but you can still learn how to boost your resilience. And the first thing is know your stressors. What are the signals that you notice that you are stressed? And learn how to manage your emotions. For the one is that talking to someone, another person will go for running or go in bath or having a good chat or having a film. So know what is helping you to manage your emotions. And then you can have a nurture growth mindset. And that's not easy. You can learn about it, but you have to put effort in it. Accept input from others and take time to refresh. That's very important. Take time for your leisure time and to think not about your work. Well, the organizational interventions that are look at work schedule, improved ICU work environment, and indeed educational modules. We can learn how to respond to the difficult situations. And this was a nice study that was found that it was really effective to have those educational modules. And another thing is to stimulate a healthy lifestyle. And for example, in our hospital, we have now our own fitness, how you say that? So to provide the people to have a healthy lifestyle. And you can do that also, for example, in your own ICU team. Organize a week of healthy lifestyle with a dietitian or with other people who can provide you with the knowledge how you can build that up for yourself. And this was a nice article written about how we have autonomy and professional growth. And it was written how we can help the nurses with that. But I think it's more broad, and it's not only for the nurses, but every healthcare professional can have help from that. And I think it's important to have that recognition and respect for who you are and your knowledge, and so that you can have your identity and your sense of belonging to why you came into the ICU and why do you like your work in the ICU. It's also about role and responsibility. And if you say, well, you have autonomy and you have your own clinical leadership, then you have to take it. And then it will bring you back to why you came into the ICU, and that you can provide person-centered care, and that you can have a humanized intensive care. So that will have a resonance with your own values. Well, and if you say what is most important, I think it is, again, that balance between personal and organizational strategies. But it's important to have first your survival, and we noticed that during the COVID that it's important to have your lunch, to keep hydrated, to have access to the toilet. That's just basic. And if you are not having that, then you have very big chance to go disengaged and dismotivated. And if you look at the upper part of this hierarchy of well-being needs, then you see the inspiration of others, your self-growth, and that is related to building up your resilience. So I think there are a lot of strategies that you can use and that you can take into for yourself, but also in the team, and that you can relate to the work engagement and have your job satisfaction and your healthy work life. So to conclude, resilience and autonomy and also vitality are crucial for personal well-being at work. Work engagement and fulfillment can counterbalance stress reactions, and social support and meaning in work life are most important factors. And so I will say, stay strong together, and that will help to build your resilience. Well, thank you for listening and listen to this presentation.
Thank you so much, Margot. Fantastic presentation. And I think in particular, looking at the balance of organisational and personal responsibility for burnout, both in recognition and management. We've got a load of questions on the chat. So I'm going to hand over now to Katerina, who's going to field a couple of the first questions. So please keep putting them in on the live chat and we'll come to them. But Katerina, over to you in the first instance.
I would like to thank our speakers for their amazing presentations. Margot, I have a question for you. Although it was evident from your presentation that enlarging resilience is a multi-layering approach, you talked quite a few times about leadership. That is an important factor for growing resilience and work engagement. Can you please tell me how you see this concept in daily practice of an ICU nurse?
Yes, thank you for this nice question. I didn't go into deep in leadership because that's a very broad topic. And I think it's in two ways. Of course, we can think of leadership in the managerial way, so that you have your managers who are inspiring you, who can also listen to you, who you can talk to if you have stress or if you want to talk to someone. So that is a very important part that should be available in every ICU. But I think it's also the clinical leadership of every healthcare professional, but certainly also for ICU nurses. And that is a step we have to take now, and it's growing and growing. We have to take our responsibility. We have our knowledge, we have our domain, so we can have that clinical leadership and that autonomy to take advocacy for our patients. And in that way, you can connect to the patient and to the families and to have that part to do something extra. And in that way, you can feel the engagement and why you are working in the ICU and that it's nice to work there. So then it can have that counterbalancing effect of work-related stress. So leadership, well, we can talk about the week about leadership, but I think it's very important to have that clinical leadership coming up for your patients, having that human-centered ICU. And if you are working on that domain and that part, then I think that can help you.
Thank you very much. So let's go back to basics. Yes. Suzanne, can I ask one more question to Margot?
Yeah, of course, go for it.
You mentioned also several strategies to enhance well-being at work. What is the most important according to your opinion?
Yeah, that was why I found that nice picture of the pyramid. I think, of course, the basics is most important. If you don't have the basics, well, then we fell down. And it is important to look at yourself. What do you need most? And for the one that will be having your work schedule, having your colleagues, having a nice team, and for another person that is more related to your own personal vitality or your spirituality, or have your belongings or your meaning in work life. So what is most important is still that mix of all those factors. So I don't have that golden reason or golden measure that will help, but you have to figure out for yourself what will help you most.
Thank you very much. I think, Suzanne, there are a couple of questions in the chat.
I've got some questions that are coming through, so thanks for people who are posting. We'll do our best to get through them. So the first one, Ellie, is to you. It's a little bit political, so brace yourself. There's a question about understanding that burnout is the responsibility to an extent of the healthcare worker and the employer. And looking at balances of expectations and rewards, that's come up quite a lot. I think you won't be surprised that pay for healthcare workers has been brought up in the chat. Is that contributing at all, do you think, to burnout in the healthcare workforce at the moment?
Thank you, Susanna. I think that the question is important, and you phrased it very nicely in the right order. I believe that, of course, any kind of reward and any, if we are able to value the work that is done by any means, that is good and it is very professional. However, I might bring some arguments against this hypothesis. One is the countries where salaries are much higher in nurses and even very close between doctors and nurses are not countries that are spared from burnout. And there are very nice data from Switzerland, from the UK, from the US, and you can imagine that the salaries vary a lot as compared to South Europe, for example, and the prevalence of burnout is very, very close in those countries. The second argument is that we have measured and we have collected information on salaries in previous studies, and it has never been associated with a decreased prevalence of burnout. And the last thing is, yes, there's a need to reward and to value all the wonderful job that is made in the ICUs. However, it cannot be considered as the only factor. It's a dynamic between different factors. As you know, if you have a chaotic work environment or a very bad ethical climate, whatever is your salary, you're going to suffer. And I think that we really need to see that as an entire process. And when we have the arrow that I showed and then Margot showed that are leading to burnout, I think that the equation is very simple. A little bit of everything can lead to a very bad situation. So yes, I'm deeply convinced that our professionals need to have higher salaries, even in countries when they are high enough, because you know, at this time, and the COVID-19 has shown that we are at a time where we need to value those people, and we need to give more incentive to the young generation to come and to work in the ICUs. And we know why, because we are passionate about what we do, and we know that we have something to pass. But when we are now very much working with the European Society of Intensive Care Medicine on burnout, and we are really paying attention to that, and I must say that even in qualitative research, salary, maybe for bad reasons, but it's not something that is really shared by the professionals during semi-structured interviews.
Okay, really interesting. So now I've got another couple of questions So first one, I think to Margot, probably, since Margot is the solutions person here. There's a question on the chat that says, so this is all very nice. Thank you very much for everything you've suggested. But what if you're working in a low or middle income country, or part of a country that is low or middle income, where this really isn't seen to be a priority? What strategies would you suggest there?
Yeah, that's a very good question. Well, I think I hope I emphasize that one of the most important factors is the social support. And you don't need any money for that. We can do that just by listening to each other, having that attention to each other. Maybe you can do that with a cup of coffee, or maybe at the end of the shift. How was it, or how was it for you? That kind of intervention, we can do that as a healthcare team. And I would really like to have that as an interdisciplinary effort to have time for that. So that is a question that is a matter of culture, and that was so nice from the study of personal fulfillment. We have to emphasize that culture of looking at each other, of personal fulfillment, that it is important to stay engaged with your work. So also in low and middle income countries, I think you can do already about that. If we look at the personal things what you can do, how you stay healthy, how you stay vital, I think you can do that by yourself, and also you can have some nice clinical lessons from a dietitian or from a physiologist, what you can do. And that's very inspiring to have something that within your ICU team. So that are already some methods you can, I think, apply everywhere.
So it's about understanding we're all humans.
Yes.
But actually being active about looking after ourselves rather than passive. I hear from you, and being active about working as a team and looking out for the team rather than just sort of expecting it to happen around us. I think Katerina has got a couple of questions on the chat. Katerina, over to you.
I have a question for Katerina Rusinova. You talked about metrics, you talked about algorithms, and we know how important this aspect is to have a tailored, precise treatment. How the concept of compassionate care could align with metrics and algorithms? Do you see that medical and nursing education might be change their strategy to include compassionate care in the basic study?
Thank you very much for this question. This is an excellent one. Checklists and algorithms are rather easy to apply, and things about compassionate care and the paper I mentioned from Randy Curtis, this is more about the culture. The way we do it at the First Faculty of Medicine here in Prague is to take the left side of that column that I showed. It was the patient voice and patient perspective, and we try to introduce and include this into medical students training. How we do that, we understand that hearing the patient voice means taking a value history or doing a screening about how the patient and the family understand what are their values and preferences. And so we decided in our faculty, and I think it's a part of curriculum in almost every medical school now, to teach early in the course of the medical studies, to teach medical students to be attentive, to pay attention to who is me in the room, to teach about the values and preferences. And I think this is the first step to help the next generation of doctors and nurses to acknowledge the left column of my figure, to acknowledge that we only can honor good ethical climate. We can only do that by combining the two ways in our reasoning, the medical, the evidence-based reasoning and the patient trajectory, and understanding more from the patient. So that would be my answer, how to do it. I think if you study curricula from Harvard Medical School, from from UNIC or other medical schools, we are all trying to introduce into our teaching in recent years.
Okay, thank you very much. And I think, Suzanne, there is one more question in the chat box.
There is, but I think for the sake of time, unfortunately, we're going to have to wrap up. So I'm going to say thank you on behalf of me and my co-chair to all the presenters for their amazing presentations and great insight. Particular thanks to the ESICM for hosting this actually really important webinar and putting burnout even higher on the agenda. I think we've all learned more about burnout and stressors, the importance of therapeutic relentlessness, which a lot of people picked up on in the chat, and what it can do to us as clinicians, the importance of recognition of burnout in ourselves and also our colleagues, and some potential solutions, some high intervention and some relatively low that we can undertake as individuals, but as employers and leaders ourselves. I think for me, ICU staff wellbeing clearly has to be a priority. And I'm really looking forward to working together in the future to keep the issue high on the agenda and find potential solutions. So I say stay well all. Thank you so much for attending today and see you soon.
Thank you very much.
Thank you.
Thank you and goodbye.